All right. So it's about 10 o'clock. So our time. So why don't we resume? I see everyone is coming back. So the next talk this morning, I'm really pleased to welcome Dr. Rondell Graham, who is the head of GI and liver pathology at the Mayo Clinic. Really a very really authoritative voice in the area of liver tumors, and I'm really happy that you're able to join us for this presentation on sort of diagnosis of hepatocellular carcinoma, and I'm sure other liver tumors as well.
Perfect. Should I begin?
Yes, please.
Oh, thank you so much, Jonathan, and thank you to you and Dr. Reston for the opportunity to be a part of this course, working with the fantastic people here as General Brigham. I'm going to make sure that I'm showing you the right slides, and let me just make one adjustment here, and I'll restart the PowerPoint. I just want to make sure to, oops, I clicked the wrong button.
Yeah, you had it originally.
Perfect. So thanks everyone for joining today, and I'm convinced that if I can keep you engaged, we're going to accomplish some important things in liver pathology diagnostics. And for those who stayed to day 3, I think liver is one of the very best parts of the GI tract. So by the end of this presentation, I'm confident if I can keep you engaged, we'll be able to distinguish hepatocellular carcinoma from hepatocellular adenoma. That's an important distinction. Hepatocellular adenoma from dysplastic nodules. You'll be able to list a panel of special stains to aid in diagnosis and describe an algorithmic approach to handling a liver specimen with a hepatocellular lesion. So I'm going to start with a case, and this particular example is from our practice, a case that I received last month, a liver lesion, and you can see at low power, there's some inflammatory infiltrate sprinkled throughout of it. But the crucial thing is you have a lot of these unpaired vessels and an absence of intact portal tracts as a feature of a neoplastic process. On a higher magnification, you can see these unpaired vessels again, and you can see a hepatocellular proliferation where each of the hepatocytes appear like their neighbor. And so it's bland appearing and kind of a diffuse proliferation without intact portal tracts, immediately inviting a question as to what type of hepatocellular neoplasm is this. I'm using this high power to illustrate that the neoplastic cells are really bland appearing. Even on this magnification, you can see bioproduction, which is diagnostic of hepatocellular differentiation, but no real atypia that you can appreciate on the H&E stain sections. And this was true throughout this lesion. I did a HEPAR for illustration purposes here to show that indeed this did express HEPAR1 arginase was positive as well, but the reticulin stain disclosed a disruption in the reticular network. So an intact reticular network should show hepatocytes each touching reticulin. You can see in this field of view that there are multiple hepatocytes which are not touching our reticulin fibers, supporting the interpretation that the reticulin was disrupted. And again, glypican tree shown here was essentially negative. But despite the negative glypican tree, I think one can be confident that this is an example of a well-differentiated hepatocellular carcinoma. So with this illustrative case, I want to highlight the key pieces of clinical information that I look for, and I think you should look for when you're going to make a diagnosis of HCC. So I think it's important to know how many lesions are present in the liver. It's useful to have an idea of the size of the lesions. The status of the background liver is really, really helpful. So patients with cirrhosis or chronic liver disease are much more likely to have hepatocellular carcinoma, although this isn't guaranteed at diagnosis. It could be a dysplastic nodule and very rarely an adenoma. Again, very rarely an adenoma. A history of vascular disease, and by that I'm really specifically referring to a vascular malformation syndrome or vascular liver disease. That's really a complex area. We won't go into detail on it in the slides. These are really uncommon. They're not present in greater than 1% of the population. But if you encounter a case like this, I think it's a good idea to consult with an expert liver pathologist. And of course, a history of malignancy or prior chemotherapy is really helpful, whether it's in the therapy directed to the liver or elsewhere in the body, really helpful clinical information to have. This is a table summarizing the key features that I pay attention to and I find to be discriminatory between hepatocellular adenoma and well-differentiated HCC. Patient sex can be helpful, so too cirrhosis, as mentioned before. I've included some features that I think are not helpful per se, but it's useful for you to be aware that it's possible in both adenomas and HCCs, and this will be intralesional fat is possible in both of these. Reticulin loss, if it's more than minimal and focal, I really think that that is diagnostic of a well-differentiated hepatocellular carcinoma. And a proliferative rate that's greater than 5% in a lesion that hasn't been ruptured, I think also will strongly support the interpretation of an HCC. And in a nuclear tip that's severe or more than focal, meaning I can find it in more than one microscopic field, would support the interpretation of a well-differentiated hepatocellular carcinoma. Nuclear accumulation of beta-catenin can be seen in beta-catenin activated adenomas, but it also is a feature of about 25% of hepatocellular carcinomas. Glypican-3 expression, as I mentioned before, supports the interpretation of an HCC, and I've included the immunostains used to subtype hepatocellular adenomas here to highlight an important point that while these stains are useful to subtype hepatocellular adenomas, if you perform these stains on hepatocellular carcinomas, you will get a range of results. And so these stains by themselves don't allow for distinction between adenoma and hepatocellular carcinoma. And molecular testing can be helpful. This was highlighted in an abstract at a recently concluded USCAP annual meeting. The molecular background for hepatocellular carcinoma is quite different from what you will see in a hepatocellular adenoma. I don't think that people are doing this kind of routinely for this purpose on all cases or routine cases, but there are challenging cases in which a molecular approach can be helpful and can illuminate the diagnosis. So I'm going to show you another case again, just from our practice, this time from a patient with a background of liver cirrhosis. You can see the nodules in the upper right-hand portion of the image. And you can see a hepatocellular proliferation here that stands out, much more intratumoral steatosis than you see steatosis in the background liver. On a higher magnification, you can appreciate that there's a little bit of intratumoral fibrosis. You can see these unpaired vessels and sheathed by a collagen, and there's just this appearance that the liver is divided into trabeculae. When you have fat, it's always challenging to evaluate the reticulin stain because fat by itself disrupts it. But you can see even in these pockets without steatosis, you can see a disrupted reticulin network supporting the interpretation of a well-differentiated hepatocellular carcinoma. And so I've included a table here to illustrate how I distinguish between dysplastic nodules and hepatocellular carcinoma. And without repeating all the things that I said previously, one thing I'd like to highlight is that keratin 7 can be quite helpful in this context. It's highlighted in the WHO as a useful tool. And if you apply it to a dysplastic nodule, what is characteristic is the nodule will be embraced by a ductal reaction that the keratin 7 will highlight. Whereas hepatocellular carcinoma typically, not always, but typically will not show that rim of keratin 7 positive ductal reaction, just kind of embracing or encircling that nodule. And that can be a helpful tool. Nuclear expression of beta-catenin, again, in this context, would support an interpretation of a hepatocellular carcinoma, and a positive Glypican-3 also would be a helpful test. Again, molecular testing not widely used or commonly used, but can be helpful in this context because of the molecular complexity and heterogeneity seen in HCCs that stands out against what you would see in a liver with just cirrhosis alone. But the chief thing is to pay attention to the morphologic features, and a reticulin stain can be very helpful together with a very limited panel of immunostains. So this is the panel of stains that I typically look for, or I would typically utilize when I'm going to make a diagnosis of HCC. I often will have an Oscar keratin, that's the pan-keratin that I like to use to confirm a line of differentiation. I like to use albumin and cytohybridization or arginase as my markers of hepatocellular origin. They should be strong and diffuse. If they're not, that certainly opens my range of possibilities to consider other things. It really depends on the case, but ideally it should be strong and diffuse. I like to use reticulin in non-fatty areas. It's very, very helpful to support an interpretation of hepatocellular carcinoma in the appropriate context. I use a Ki-67 to look for the proliferative rate. A low proliferative rate may not be really helpful, but if it is really high, it can be really supportive of a diagnosis of malignancy. And I will often do a glypican tree to support a diagnosis of malignancy, and we'll touch on this more later. Glutamine synthesis and beta-catenin can support beta-catenin activation, and in context will be really helpful. And keratin 7 in the context of cirrhosis can be helpful in supporting a diagnosis of malignancy, specifically by looking for that ductal reaction around reactive nodules. That said, I think the main tool is to carefully review the H&E stain sections and to be cognizant of what is going on in the patient's clinical history and workup. There's some expert pathologists who like to pay attention to the history right away before they look at the slides, and others who prefer to look at the slides first and then pay attention to the history. I'm not sure that either approach is better than the other. I think you have to pick an approach that works for you. I think the key is to be systematic and to ensure that you carefully review the H&E stain sections and that you have awareness of the clinical picture. The sequence of those things, I think, is less important. What's more important is that you do them in a systematic and structured way. So invariably, I'm asked in presentations like this, and even in routine sign-up when I'm working with residents and fellows, what about CD34? And I think CD34 is a useful stain. If you're using it and you find value, I encourage you to continue to use it. I'll illustrate why we typically don't use it in our practice. We have about a dozen GI liver pathologists in our group, and I will say that just from observing the patterns of my colleagues, almost none of us use CD34 consistently. If we receive a case of CD34, we'll look at it, but we typically don't. Some older literature on CD34 you can see here from 1996, showing that it's strong and diffuse in the sinusoids of advanced HCC, but is more variable in early stage HCC, which is where I think it will be much more helpful. There are data, again, around that time, about 20 years ago, showing that diffuse sinusoidal CD34 can support a diagnosis of HCC, but indeed, even in this study, reticulin stain was much more effective at distinguishing HCC from benign lesions, and that is our practice here in Rochester. That said, in AJSP, now this is a little more than 15 years ago, complete CD34 sinusoidal expression was seen in virtually all the HCCs, but it was seen in a small subset of benign lesions. And where you see incomplete or patchy CD34, it's rare in HCC, but seen more commonly in benign lesions. So because of this kind of heterogeneous data around, or data showing variability around the utility of CD34, especially when you have other markers that are helpful, this is why I don't use CD34 much. But if you use it and you find value, looking for complete CD34 sinusoidal expression, I encourage you to continue to use it. So with that said, this is kind of the algorithmic approach that I kind of take. I try to confirm first that I'm looking at a mass lesion, so looking for the lack of portal tracts and the presence of unpaired arteries. I confirm epithelial differentiation. I want to confirm a hepatocellular phenotype, and then I want to look for architectural, cytologic, and nuclear atypia. Of course, if I have all three, that's lots of atypia, that will be really supportive. But I think finding architectural atypia and the loss of reticulin by itself is kind of the minimum set of criteria, with the others layered atop that. And sometimes I identify other features of malignancy as well, because those can be supportive. For example, yesterday I had a case with foci vascular invasion, which was supportive of the diagnosis. So I've included this slide here to say, when am I descriptive? I'm descriptive particularly in biopsy cases. If it's a biopsy where I don't have any unequivocal features of malignancy, so the reticulin is intact, or it's just kind of lost in one focus. If I don't have a complete clinical history, or the history is not suggestive of malignancy, I may be descriptive on that biopsy and defer the final diagnosis until it's resected. And then if the patient has a history of vascular malformation disease or congenital vascular heart disease with liver lesions, that's a biopsy case that I'm going to be much more careful with, and the workup is going to be a little more extensive than what we're talking about today. So I'm going to transition and change gears to show you a different part of the spectrum. I'm showing you just kind of classic cases that come to my attention. This is a 30-year-old woman with an incidental 3.6 centimeter liver lesion, shown here on the cross-sectional imaging, pointed to by the blue arrow. So this is, again, a lesion where there is kind of all the cells kind of look the same. There's an abundance of intratumoral steatosis. On a high magnification, you can see no intact portal tracts. You just have multiple arterial profiles and sheathed by kind of a thin sliver of collagen. The hepatocytes appear all kind of uniform, very similar to each other. And in the panel away to the right, again, unpaired arteries, intratumoral steatosis, a little bit of inflammation, but a bland appearing lesion, small in size, 3.6 centimeters in this young woman. The reticulin stain was intact. You can see here each hepatocyte touching reticulin fibers. That's a good appearing reticulin. And you can see these areas here where you have this dilatation, this marked sinusoidal dilatation, both on the reticulin and on the H&E stain section, which is characteristic for this lesion. So this is the hepatocellular adenoma, and I intentionally put the diagnosis first because then we use the stains for subtyping, and you can see strong and diffuse expression of C-reactive protein and serum amyloid A, together with intact LFABP, that's a normal result, and no nuclear accumulation of beta-catenin, that's a within normal ranges result as well. And this will support the interpretation of an inflammatory type or telangiectatic type of hepatocellular adenoma, the latter name corresponding to the sinusoidal dilatation. So with that, I want to talk a little bit about hepatocellular adenoma classification. At a recent USCAP meeting, we recognized in a hot topic session that lots of colleagues are doing subtyping in their practice. And so I'm going to touch on it for those who are interested. So hepatocellular adenoma is benign, but there is some risk of malignant transformation. The degree of risk varies by the types, and the frequency of those types varies based on where those studies were done. You'll see a frequency of those quote-unquote high risk or beta-catenin activated or atypical adenomas in studies from Europe or higher risk seen in Europe, but I think that may be based on variation from center to center. So there are 4 subtypes of hepatocellular adenoma that I think you really need to know about. And here they are illustrated. It's useful to be aware of them because of the risk of malignancy. In the darker blue, about 30% of hepatocellular adenomas are HNF1 alpha mutated and show loss of LFA-BP1. They're in 10%, this is based on data from the French group. I think this is much more frequent there than we see it in our practice here in the US. Those are the beta-catenin activated adenomas. The inflammatory adenomas comprise about 50% of adenomas in their studies. And then there's kind of an unclassified group. You'll hear more talk about this in the academic literature, but I think that a lot of that is really of academic interest and interests me, but I don't think is ready for prime time in routine clinical practice at the moment. I've included this table in your slides because I think it's really helpful to correspond the genetic alterations with the clinical characteristics that are typical, along with the typical histologic phenotype, recognizing that these findings may not be seen in all cases, and the corresponding immunohistochemical result. And this is available for your review at your convenience. So I think it's crucial, and you'll see me kind of over-communicate this, to make the diagnosis of hepatocellular adenoma first. And I think you want to distinguish it from normal liver. This actually happens in our consultation practice. People will send a biopsy, curious about hepatocellular adenoma, but they have a liver biopsy with normal portal tracts throughout, and that's actually normal liver. That's an important distinction to make. I think it's important to distinguish hepatocellular adenoma also from focal nodular hyperplasia. Crucially, the latter has a nodular configuration that's usually apparent on the biopsy. And I think that's the most sensitive and specific, using that combination of sensitivity and specificity feature to pay attention to. The central scar comes next with the fibrous septa, and then you'll have these thick-walled or funny-looking arteries, and then thereafter the ductal reaction, followed by a map-like expression of glutamine synthetase. I think that captures the diagnosis. I would say these features, the map-like expression of GS, these funny-looking arteries are features that you don't see in hepatocellular adenoma. And again, that nodular configuration microscopically is quite distinctive. Here's a panel showing the classic features of focal nodular hyperplasia. Here is the gross image with that central scarred area. You can see the nodularity here. And again, in the panel just beneath, you can see this nodularity that just comes out in a striking way microscopically. Here, again, adjacent to the scarred area. And you can see this map-like or geographic expression of glutamine synthetase, which captures the diagnosis. So distinguishing adenoma from HCC, I've alluded to this before, but I really look for architectural atypia, thickened plates, which a reticulin stain will highlight, but also a nodule architecture. Those will be findings that will be out of keeping with an hepatocellular adenoma and will support malignancy. And if I see multiple areas where there's pseudoacinar forms with cholestasis, if I see that in more than one focus, to me, that's too much to be in the adenoma category. We're thinking HCC, and I've alluded to these other characteristics previously. So to kind of summarize this portion, which is how do you make the diagnosis of HCC, where you're thinking about these benign mimickers, I think you need to carefully attend to the clinical features of morphologic findings, with well-differentiated HCC being distinguishable from its benign mimics because of having more than minimal atypia. So anything more than minimal, is you see it in more than one microscopic field. If you see glycogen tree expression, I think you're on the side of HCC. If you see more than minimal atypia, you lack that embracing or encircling that to the reaction, and you have reactivation of that oncofetal antigen glycogen tree, you're in the category of well-differentiated HCC. And I feel like by this time we've gone through the algorithm of how to make that diagnosis, and it's included in your slides. With that, I'm now going to pivot to the second portion of the presentation, is when you're thinking about other malignancies. So there's some HCC specific clues that I want to be aware of in this second half of the story. And this is that cirrhosis increases the likelihood of HCC, but it does not exclude metastasis. So you can have a metastasis in a cirrhotic liver. That's just something to be aware of. And the presence of bile production supports the diagnosis of HCC. With those clues aside, I think it's important to be aware that HCC really has a heterogeneous appearance. It's heterogeneous within tumors commonly. So HCC is more commonly heterogeneous than it is homogeneous. That's something useful to be aware of. But also HCCs vary a lot across them. So various HCCs look variably. Now, the WHO has a criteria for grading HCC, and I think those criteria are really intuitive, and I've included some information here in the slides that will be helpful to you. But I think these criteria from the WHO are really, really helpful. Well-differentiated HCC looks like normal liver. Poorly differentiated HCC, you're convinced is malignant, but you need to do some immunohistochemical studies to confirm a hepatocellular phenotype. Moderately differentiated HCC is between those extremes. So while I think this classification is useful and is intuitive, that means that about 85% of HCCs end up being classified as moderately differentiated. So that's just something that I think is useful for you to be aware of. And next, I'm going to show you 3 different HCCs that just kind of came through our practice, just to give you a sense of this kind of variability. And here they come. So here's one well-differentiated HCC, or some people might consider this moderate, but to me, this is reasonably well-differentiated. The reticulin was lost, but this is an HCC that really has a trabecular pattern of growth that superficially mimics a neuroendocrine tumor. And so that's a differential that you need to be cognizant of, depending on what clinical information is available to you. You can see some mitotic figures here at low power. And again, you can see mitotic figures here. Again, this is a rate of proliferation way too much for me to think of an adenoma, because in adenomas, you struggle to find mitoses. HCCs with clear cytoplasm, you can see them. Here you can see bizarre looking nuclei again, way too much atypia. This is an HCC, but again, you need to be cognizant of the differential that is associated with clear cytoplasm. And you can see some HCC with some just bizarre mitoses and just really atypical cells, and sometimes with intratumoral fibrosis, as shown in this example. HCC has many, many faces. But crucially, I think you want to use an algorithmic approach when you're encountering liver lesions. You're convinced this is a neoplastic process, is probably malignant, although not necessarily. You need to use an algorithmic approach. Here's a case that I received in consultation, a middle-aged patient with a solitary liver lesion. You can see unpaired vessels present here, or vessel not with a portal tract. I think this microscopic field is really the giveaway in this particular case. You can see abundant eosinophilic cytoplasm, sometimes pushing the nucleus to the periphery. And this case was completely arginase negative, which I think was an alarm bell, but not initially recognized by the submitting pathologist. This is an example of angiomyolipoma or pecoma. It was positive for both melanocytic and smooth muscle markers. The key here is this algorithmic approach. I think confirming hepatocellular differentiation is really key, either by bioproduction or arginase or another hepatocellular marker. So one of the things I like to do when I'm working up a tumor is to make sure that I've assigned the line of differentiation. I've included in the slide here the lineage markers that I really like. Depending on the case, I will use some or all of these. If I end up using all, it would be a really weird case, like a case of an unknown primary with no history. But usually I will end up using a sampling of these, and I've included the markers that I really like. I've included here a helpful tip because I think this comes up not infrequently. Keratin expression in high-grade tumors doesn't guarantee a carcinoma. It really depends on the context. That's true for all immunohistochemical markers. But I would say older patients, patients with cirrhosis, trabecular growth patterns, and pleomorphism are features that help me to think this is possibly an HCC. But then I need to interpret the full immunophenotype in context. And so this is how I think through the case. I think about the clinical context. Is there background pre-neoplasia? How do the cells grow? What's their pattern of growth? Because some patterns are more common in epithelial tumors, some are more common in HCC, as a for instance. I look at the morphology. Is this a pleomorphic tumor or not? What do those cells look like? And I interpret the immunophenotype in context. What do all the markers look like, and what do they look like in the context of the preceding information? So here's an example, 65-year-old liver mass. This was sent as an HCC. In fact, all of the cases that follow were sent initially as HCCs, but there's some important clues. That case kind of had a sheet-like proliferation. You can see mitotic figures here, and there is quite a bit of cytologic atypia even in this field of view. But this field of view shows these kind of targetoid intracytoplasmic inclusions, which are kind of a giveaway that this probably isn't an HCC. And this spotty heparin, which was submitted with the case, is a little bit of a source of worry. The pankeratin that we did was completely negative, which now should have alarm bells ringing. This case showed an expression of inhibin and synaptophysin, confirming that this is indeed an adrenocortical carcinoma mimicking an HCC. What I'll say about this in continuation is that I've seen both adrenal and right side renal masses misinterpreted as liver masses by radiologists, including excellent radiologists. So I think it's important to be aware of those possibilities. This table describes the mimics of hepatocellular carcinoma that I've actually seen submitted as HCC in consultation in our practice, along with the immunostains that I think are helpful to distinguish them. You can see here that it really only takes a small panel of immunostains to really exclude these possibilities, especially if you consider the available clinical context if you have it. You'll see that keratin 720 negative, which is typical for hepatocellular carcinoma, can occur both in prostate cancer and renal cell, and also can occur in adrenocortical carcinoma. But those are really only the differentials for keratin 720 negative malignancy. So those are the top four that I have top of mind, and the other stains are listed here. Crucially, I'd like to encourage people to make sure that the lesion is keratin positive if they're going to diagnose HCC. Again, oftentimes it depends on the context, but I've seen this mistake happen with adrenocortical carcinoma. I've seen it with angiomyolipoma, and I've seen it with melanoma before. Of course, melanomas can express keratins, so I'm not saying by any means that this is absolute. But again, this is why a systematic approach is really, really helpful. So I hope by now I've convinced you to use special stains. I think while you use them, it's crucial to understand their limitations, and this next case illustrates that. So case is from a 60-year-old woman who presented with a liver mass, lots of clear cells with clear cytoplasm here, lots of atypia. I don't think there's any concern that this is likely to be something benign. But this case showed an abundance of intracytoplasmic mucin. So while it expressed HEPAR, this really was a hepatoid adenocarcinoma from a patient with a prior gastric mass. And the arginase in that particular case was completely negative. Hepatoid adenocarcinomas are uncommon. They're not very common. Presenting as metastases, I should clarify by saying presented as metastases. There are other things that kind of present much more commonly than these, but they may mimic HCC, but the finding of intracytoplasmic mucin and true gland formation are very helpful clues. The majority of them are going to be from the stomach and the GE junction, although you can see them as primary lesions in the lung as well. And maybe I'm biased in thinking that the majority are from the stomach and the GE junction. My pulmonary colleagues might think differently about that. I think crucially, you don't want to rely on CDX2 alone to make this diagnosis, while it can be positive. And the reason for this is that there is literature out there, some from our practice here at Mayo Clinic, some from practices in New York City, showing that CDX2 and SAPB2 both can be expressed in hepatocellular carcinoma. So I think the crucial thing to pay attention to is look for true gland formation, intracytoplasmic mucin, and pay attention to the clinical context and the history. So this brings us now to the hepatocellular markers, because I think this is the important area. Arginase is the hepatocellular marker, or IHC marker, that I like the most. This was originally kind of presented from John Hart, working together with a group of outstanding liver-focused pathologists, and they were able to show that looking across all the HCCs, arginase was the best marker. But if you take both, if I should restate that, arginase was really the better marker when you compare the HEPAR1, looking at just the extent of staining, but also when you look at the strength of staining, arginase was also superior to HEPAR1. These are additional data from that study show you that HEPAR1 tends to be positive in a subset of gastric adenocarcinomas. Again, we talked about this earlier. The hepatoid gastric adenocarcinomas tend to be HEPAR positive, but not positive for arginase. And this is why I like that marker. Although it's not perfect, you can see it was expressed here in a prostate cancer. So sometimes I'm asked about polyclonal CEA and CD10. Candidly, my colleagues and I rarely, if ever, use them. If they're sent to us, we'll interpret them, of course, but these are markers we rarely use, but they do highlight a canalicular pattern, and that's why some colleagues will use them, but again, not in our practice. How about Glypican-3? We've touched on this quite a bit, so I'm including some more information on it. Glypican-3 is an oncofetal antigen. It's not a specific marker of hepatocellular lineage, so it can be expressed in germ cell tumors, rarely in gastric carcinoma, and some other types of tumors. But like all immunohistochemical stains, it needs to be used in context. It is, if you find it to be diffuse, that's a strong evidence for ACC, again, in the appropriate context. These are hepatocellular lesions, but it's frequently focal and sometimes can even be negative, especially in well-differentiated tumors, as you can see here in this study from Han and Wang, published in archives about 15 years ago. But I think that this still maps closely with our practice experience today. So to summarize some findings from needle biopsies, again, this is a study from Han and Wang, also in 2018. If you look at needle biopsies, Glypican-3 is still helpful in that context. But again, even in needle biopsies, well differentiated, ACCs may be negative and may be negative frequently if you rely on Glypican-3 alone. But it's still a useful marker in that if it is positive in that context, it is quite helpful. Albumin in situ hybridization is a relatively new marker to be used widely, but has been used in our practice for some time, going back almost 20 years as a highly sensitive marker for ACC. What led to its use is because only hepatocytes produce albumin protein. But I want to emphasize that the production of the protein, while specific to hepatocytes, the production of the RNA, which is what the in situ hybridization detects, is not 100% specific to ACC. So while quite sensitive, data from our practice just a few years back showed that rarely it can be expressed in other things. For example, acinar cell carcinomas can rarely show albuminish expression. You can rarely see it in breast cancers, and also you can see it in gallbladder adenocarcinoma. The sensitivity, though, is really, really high. And so if I see a case that's negative for albuminish, I'll be very hesitant to call that an HCC. My preferred hepatocellular markers are arginase and albuminish. I find these to be the best of the lot, but other markers do contribute. Glypican-3 and reticulin do contribute. Reticulin loss in the appropriate context I find to be very helpful. And I do use Ki67 to assess the proliferative rate. Other markers that can be used are HEPAR1. Many people use this marker still. I do use it as well. I just prefer the others above. Polyclonal CEA is used for that canalicular pattern, but I would say we don't use it in our practice. Neither do we use bile salt export protein, which again is going to highlight a protein on the canaliculus. So distinguishing HCC from cholangio is a topic that does come up. I've included some markers that may be helpful. Albumin is helpful once you are aware that intrahepatic cholangiocarcinomas are often positive. Arginase, again, being a much better marker, in my opinion. BAT1 can be used to make this distinction. And I would add here that molecular testing can be helpful if it comes to that, because the molecular signatures for HCC and cholangiocarcinoma are quite different. But I would say that this is not needed in the vast majority of cases. I think paying attention to the morphology chiefly, and then the immunohistochemical markers can aid in this distinction. As I mentioned before, molecular testing can be helpful because the common HCC mutations are different from what you see in extrahepatic and intrahepatic cholangiocarcinoma, and I've described some of the common things used to make this distinction in the bullets that follow. So one of the questions that comes up, again, I actually got this question yesterday, what about combined HCC cholangio? I think definitionally, based on the WHO criteria, this requires clear glandular and HCC components, and it is based on the more recognition of those components or morphology alone. So the immunohistochemistry plays a strictly supportive role and does not override the above requirements. Emerging data from Europe, leveraging artificial intelligence and looking at some novel markers are poised to influence the direction that the field goes in relative to this specific designation, the designation of combined cholangio HCC. But I think that those are still in the research domain, and the above bullets, these two bullets, are really what one needs to pay attention to for practice today. So the algorithm that I would propose, if you have a high-grade tumor, so we're not in that category where it's kind of well differentiated, you're trying to separate it from adenoma. We're in the category where we think it's malignant for sure, and we're trying to figure out what to do next. I think it's crucial that you're aware of you have confirmed an epithelial lineage, that you have confirmed hepatocellular differentiation, and I think glypican-3 and some additional markers will be confirmative or confirmatory. I think you need to confirm the line of differentiation first and interpret the immunohistochemical and clinical picture in context, as I mentioned in the slides that preceded. So to summarize, I think a really safe approach to diagnose important differentiated HCC, or any HCC for that matter, includes establishing the line of differentiation and also establishing hepatocellular differentiation. I think it's important to use the immunohistochemistry and in situ hybridization thoughtfully to avoid diagnostic pitfalls. And I've included some common mimics to consider: cholangiocarcinoma, the carcinoma of unknown primary, adrenocortical carcinoma, renal cell carcinoma, as some tumors that can mimic HCC. And molecular testing may be helpful in some cases. So with that, I'm going to close the presentation portion, and I will be available for questions.
Great. All right. Well, thank you very much. That was a fantastic presentation. Really very helpful. We have a few questions in the from the attendees. I guess one some of these you've touched on, but maybe could you elaborate on for Ki-67 assessment of Ki-67 proliferation index? Could you define what you mean by low and high?
This is a great question. Thanks for it. We actually did a study looking at this in our group led by Roger Moreira, where we showed that Ki-67 that is greater than 3% will be considered high. So that will be high for a well-differentiated hepatocellular lesion. So that is the threshold. Anything above 3% will be high, and anything below that will be considered low.
Okay, excellent. Thank you. Another question. How often do you use albumin in situ hybridization as a marker to confirm a primary versus metastatic lesion in the liver?
This is a great question. We use this routinely in our practice. So we use this practically every day. Of course, we are a reference lab in a larger practice, but we use albumin every day. I was recently presenting in another venue, and I've started to notice pathologists in the community beginning to use albumin in situ hybridization. I find it to be a really helpful marker, as I've alluded to. That said, if you're using arginase and/or hepar, I think those are useful markers as well. In fact, I think arginase is a highly useful marker. I think the important thing is to be cognizant of their pitfalls, and then to and the same is true for Abimanish, and then to apply them in context.
Yes, context always critical. Another question, again, relating to immunohistochemistry. Do you use AFP, alpha fetoprotein?
This is a great question. So we do not, we have this immunostain in our practice, but in our GI liver group, we don't, almost none of us use it. We do use it for germ cell tumors, but to make a diagnosis of HCC, we don't rely on it. It's not a sensitive marker, neither is it specific.
Okay, let's see, and I think, well, I see there's another question. I think you may have covered it already, and so I think the attendee, I think, indicated that maybe they had their question answered, but I guess just for clarity, maybe just revisit this topic. What in the setting of cirrhosis, kind of what proportion of the time, if you're having a mass in the the background of cirrhosis, how often do you see a metastatic lesion versus a primary, or how often does that situation rear its head in your experience?
Yes, this is a really good question. I will say it is rare. So metastases in cirrhotic livers are uncommon, but they do happen. So there was some data, and I believe these data were published in a study led by Maria Westerhoff at the University of Michigan only a couple of years ago, showing that metastases will occur in about 2% of cirrhotic livers. So if the person is asking for a frequency, it's going to be about 2%. So if you're in a high volume practice, and you see lots of liver, you will see metastases. But the reverse side is that the majority, 98% of these, will be primary and probably will be HCC. But just to be aware that metastases can happen, and they do.
Okay, and let's see, another question I see just came through. You mentioned in the differential diagnosis of a dysplastic nodule versus HCC, you mentioned the presence or absence of perinodular ductular reaction. Could you describe any other criteria that you use that you find helpful for this differential?
This is a great question. I think starting with the morphology, and then I'll move into the special stains. I think the dysplastic nodules tend to be I would say maybe well differentiated, or they're kind of bland appearing. I have a cytology that is quite similar to what you see in the adjacent background liver. Sometimes they may have a little bit of atypia. Some of the cells may have maybe the NC ratio is a little bit higher, but you don't see severe nuclear atypia. So severe nuclear atypia would lead me to conclude or to strongly consider that this is a malignancy. I would also say a high NC ratio might lead me to think it's a dysplastic nodule alone, but if that is extensive, it would make me continue to look really closely at that lesion. I think mitotic figures, especially if they're atypical mitotic figures, a loss of reticulin, and a nodule in nodule pattern. So you have a nodule and then a nodule in that nodule. That kind of architectural atypia would worry me. The reticulin stain should be completely intact, if I'm going to call it a dysplastic nodule. And if the reticulin is lost, then I think it's HCC. So looking for that architectural atypia, I think, is a really helpful clue. Then together now with that perinodular ductal reaction, and then glypican-3 and other things can be used to help with that distinction.
Okay, so we have time for a few more. I think we're getting this is your talk is I think quite appropriately attracting a lot of great questions. Next one, can NRH, nodular regenerative hyperplasia, present as a single mass?
This is a great question. So the way I would answer this is it really depends on the context. What I'm beginning there is you can see NRH as a perilesional phenomenon. So adjacent to a mass, you can see NRH-like changes, and this is because of the distortion of the regional blood flow. So I think before we attempt to call NRH a mass lesion NRH, I think we want to exclude perilesional or peritumoral sampling. So I think that's the kind of the first thing. The other thing that can happen is NRH. I wouldn't say necessarily that NRH can present as a mass lesion, but you can have regional, I alluded to this before, with these kind of vascular malformation syndromes, for example, Alza-Weber-Rondeau, or otherwise known as hereditary hemorrhagic telangiectasia. Sometimes in advanced stages, these patients can have what looks like a single mass or a dominant mass lesion because of these regional blood flow abnormalities. That's a really unusual context, and I would say a case like this I would seek the opinion of kind of an expert pathologist. So the first and most common thing is I would try to exclude peritumoral sampling. I would say there's some rare scenarios where you could see a mass-like presentation for NRH, but usually with vascular malformation type syndromes, really unusual. And I would say consult an expert. It's not the diagnosis that I would just kind of make just like that in routine practice.
Yep, very, very sensible. Okay, and I think we'll do one more question. Relating to sort of dysplastic nodules, do you make the diagnosis ever of a low-grade dysplastic nodule? And if so, how would you just differentiate it from just a cirrhotic macronodule?
This is a great question, and I appreciate the attendee bringing it up. I would say I generally just describe macro-regenerative nodules or regenerative nodules. I actually don't make this distinction. And one of the reasons in my reports, and one of the reasons is that I think is not something that's highly reproducible. I would say nodules that stand out to the radiologists that come to our attention, I will characterize that as a regenerative nodule or benign or reactive, but I don't distinguish between kind of low grade and high grade dysplastic nodule in our practice here in Rochester. The key thing that would make a nodule stand out will be a seen grossly or seen in imaging, and then I will basically describe that as either benign or as malignant.
Excellent. All right. Well, again, I want to thank Dr. Graham for his lecture. It was really I'm glad you were able to join us. And I think